Okay, we're going to get started. It's 6:30, and I just want to welcome everybody. My name is Onda Quo. I'm a pediatrician at Zuckerberg San Francisco General and a professor in pediatrics at UCSF and the co-director of the Center for Child and Community Health with Dr. Dana Long, who you'll hear from later in the program. First, I want to thank you for joining us tonight to hear about the science of child transmission, safety in child care practices, and child care provider stress and resilience. And I just want to acknowledge and really thank each of you for joining us tonight to hear about the science of child transmission, safety in child and early care practices, and child provider stress and resilience. And really take a moment to acknowledge each of you and express tremendous gratitude for the care you're providing, whether you're an early care provider, an educator, a healthcare provider, a leader and representative of an agency or organization that serves young children, or are funding important early child programs, a parent or caregiver of young children, or someone in one of the many, many other roles that we all know are important to supporting children, or someone, the many people that are required to support children and their needs in these critical early years. We know that the 0 to 5 year population is unique in their needs and resources, and we also know that many providers have been open and working hard to stay open to provide the best care possible. So with that, I ask us all, I know it's 6:30, it's late, you've been working hard, so if you can all take a deep breath and send and receive gratitude. This webinar, just as a reminder, there is a link to participate in this webinar in Spanish language, and you just click at the bottom of the screen. That's me when I was in preschool. So this webinar is a labor of love from the Bay Area Early Success Clinic Collaborative. It's an effort to promote kindergarten readiness in children's health care in San Francisco, Alameda, and San Mateo counties, comprised of over 50 Bay Area leaders representing child health providers, early childhood educators, community-based organizations, and government agencies. We launched with support from early childhood champions at the Genentech and Stepsky Foundations, for whom we're really grateful. And in light of COVID-19, our collaborative has focused on identifying and acting upon ways that child health care can collaborate with early care and education to support the needs of young children 0 to 5 and their families. A huge, big shout out to our amazing, dedicated planning group, which includes Kelly Oleg Dulka from Hively, Kim Johnson from Bananas, Jennifer Caban from the Office of Policy Evaluation and Planning at the Alameda County Social Services Agency, Neva Bandaloo from the Alameda County Office of Education, Abbey Alkon from UCSF California Childcare Health Program, and Sohail Said UCSF from the UCSF Department of Pediatrics. And the Center for Child and Community Health team, myself, Amy Lauer, and Bailey DeCastro. So tonight, these are the areas that we're going to cover. We will have a Q&A following each of our 3 presentations, and then we'll end with open question and answer. A little disclosure, this evening is an opportunity to hear about the emerging science around COVID-19 for young children, childcare safety practices, and how the stress of the times impacts young children and their care providers. Our panel of experts are here to translate the facts as they understand them today. And as we all know, new evidence is emerging daily and as we speak about COVID-19 in young children. And you'll have an opportunity, so after each presentation, we will have pulled in some questions that have been through our registration. And at the same time, you will have the opportunity through the Q&A to place questions throughout the presentation that we will be collating and have an opportunity to address at the end, at the final Q&A. So I'm really grateful to present our first speakers, Drs. Naomi Bardach and Ted Ruel. Dr. Naomi Bardach is an Associate Professor of Pediatrics and Policy in the Department of Pediatrics and the Philip R. Lee Institute for Health Policy Studies at UCSF. She's also a primary care pediatrician with me at Zuckerberg San Francisco General Hospital. And she's really been on the forefront. She led a study of COVID-19 testing at indoor camps for K through 8th graders this summer and has been serving as a thought leader in the media, translating evidence via major news outlets nationally and internationally. Dr. Ted Ruel is a professor at UCSF Pediatrics, where he's the head of the Division of Pediatric Infectious Diseases. He's studied infectious disease spread in utero, as well as the treatment of children and infants living with HIV. And of course, during the pandemic, Dr. Rowell has been a leader in understanding the impact and best treatment of COVID-19 for children. And I'll turn it over to them.
Thank you so much, Anda. Can you go to the next slide? So I'm going to be doing part one, what is the risk of transmission or outbreaks? Next slide. A couple of disclosures and also acknowledgements. I'm a pediatrician and a parent, so I actually feel very strongly about the desire to have schools reopen, early child care centers reopen in order for us to get back to normal and get our kids back to normal. But I also present this data as a doctor, meaning I think about all people, and also a policy researcher. So really thinking about how do we do on the ground taking care of people's health broadly. I also want to say that our understanding of this disease is rapidly evolving. Anda already mentioned that. What I tell you today may be different tomorrow based on emerging research, although we do seem to be getting a general theme in the research that we're seeing. And then finally, this is a team sport. We have many, many thought partners and collaborators, and we are not going to get through this pandemic effectively unless we have deep, deep collaboration and communication with each other. Next slide. It's helpful to frame the early childcare conversation by sort of saying out loud that the pandemic has caused economic devastation and financial instability across all communities. We know that there's limited illness burden in children, which Ted Ruel is going to go over in our next section. But families with children bear a large brunt of the economic devastation, which is mediated through school and childcare closures. Next slide. The thing is that we focus so much on the case rates and is there a COVID case or is there not a COVID case? We're not actually tracking the harms associated with closure in the same way. We don't have that same kind of closure, that same kind of metric. And it's really important for us to balance that conversation. There's a recent article using modeling, basically trying to project what the actual results would be, finding that younger children will be most affected by school and daycare closures, childcare closures due to compounding effects over time, meaning that the skills that they lose early on, it has this ongoing effect for them. So their health is more at risk and their long-term sort of outcomes are more at risk in this particular pandemic because of the closures. Next slide. The one other really important framing for this is to highlight that educators and childcare providers are key partners. There was a narrative earlier on where pediatricians were being said that we disagree with early childhood educators or educators in general, but that's really a falsehood. There's, we know that what's good for teachers and what's good for childcare providers is going to be good for the students and for the children, and that's good for families. And so the school and childcare reopening goals are equity and safety together. Next slide. So we know more now than we did in March. It's really important to remember that. We have a lot of better information about how to prevent transmission. I do want to acknowledge that data in preschoolers is somewhat more limited, and I'll talk a little bit more about that. But what I'm presenting today is sort of what the best we know about preschoolers, and I'll try and put that into context. Next slide. So first of all, the question is, why do children get COVID-19 less frequently and have less severe disease? That's something we've seen since the beginning of the pandemic. It's not that they never get it, it's just that they don't seem to get it as often as adults, and they don't get as bad disease. And one really useful article that came out pretty early on, I think in May or June, talks about the ACE2 receptors. Those are the entryway for COVID-19, or the virus that causes COVID-19, also known as SARS-CoV-2. And they actually are how the virus gets into the body. They're the doorway into the body. And this paper showed that the ability to make the ACE2 receptor actually varies with age, with elementary students making it less than middle and high school students who make it less than adults. And so the implication from that is that if you have fewer doorways into the body, you're going to have less disease and more mild disease. And the only caveat to say is that even in young children, some can still make a lot of ACE2 receptors, which is why some young children still do get COVID-19. But this idea about the ACE2 receptor, the doorway, really helps us to better understand why we're seeing this very unusual pattern of kids not getting it frequently and having less severe disease. Next slide, please. So the other important sort of learning that we have from the data from around the world is that most children get COVID from a household contact. Even when schools are open, that's actually been seen. We've seen that in Australia, in Chicago, in China, in many places around the world. There's a few studies that look slightly different, but that's probably based on how they did their data and sort of analysis. This is a pattern that we generally have seen even when schools are open. Next slide. And then transmission among or from preschool children is not common. So passing it to and from each other or to other people is not that common. We know that there's a YMCA data from children ages 1 to 14, up to 40,000 children in over 1,000 sites, including New York City, from early on in the pandemic, where no children got COVID and only a few staff and parents tested positive, with no records of more than one case at any site. Meaning that when we were in really, really strict lockdown, there were very few cases in those sites and zero transmission. In Australia, they did a study of 10 early child care centers and 15 schools, so actually ranging from the very young to all the way up to the 12th graders. And their overall case rate was very low. Only 1.2% of people exposed got COVID, meaning that if there was a case there, they passed it on very, very infrequently. Most of the preschool cases in that study came from household contacts, which, as I mentioned before, that's the pattern we see. And then these are the transmission rates. So in those centers, there were a few transmissions, but it differs by the relationship. Child-to-child transmission was 0.3%, child-to-staff transmission 1%, staff-to-child transmission 1.5%, and staff-to-staff transmission 4.4%. So as we think about being open in the childcare setting, it's the adult-to-adult transmission that is actually a really important place for us to focus. And I try and emphasize this when I talk about it because we forget we work with our students and with our patients and with the young children in our care, and we're very careful when we work with them. But then when we hang out with our trusted colleagues, sometimes we let our guard down, and that's when the masks come off, you eat some food together, and that's where the transmission can happen. So it's really important to remember adults transmit this much more effectively than children do, and that's a really important place to be thinking as you think about your child care center. Next slide. So I just wanted to point out one thing that they did find an outbreak in an early child care center in Australia. it was one outbreak in 10 different centers, lots and lots of other data that shows there aren't any outbreaks, but this is a useful story. It was an adult index case, meaning that the first person who had the COVID in that setting was an adult. They only identified it after a child who was 2 years old became symptomatic. And it led to 6 other adults being infected and 7 children being infected, including 3 asymptomatic infants. There's one really important thing to point out. They didn't have any masking as a policy in Australia at that point. And so the take-home points from here are that the rates were very low. Adult to adult and adult to child transmission are more likely than child to adult or child to child. Masks may have prevented this outbreak. And it's important as we think about as the adults taking care of the kids that there is that possibility of transmitting. And so that masking is going to be really important, masking, hand hygiene, et cetera. But the masking is our understanding is the masking really does help prevent transmission. Next slide, please. I want to address a conversation that comes up often, which people say, but aren't children super spreaders? There's been some studies that come out that say they're equally infectious or more infectious than adults. So there's a couple studies. One was done in Germany early on in April, and then they reanalyzed it in June, and they found that the viral load, meaning when they tested children, how much viral load did they have? And they found in their series of children, their group of children, that they had more viral load, higher amounts of virus in their nose than adults did. And in a JAMA Peds article in July, they also found age-related differences in viral load in patients with mild or moderate disease, and higher viral loads in children less than 5 compared to 5 to 17-year-olds and 18 to 65-year-olds. The really important piece about this study, and the reason why I'm not worried about children being super spreaders based on this study, is that they only tested symptomatic children. And those children were people who got tested in March and April, when we did not test children very often because we knew they got mildly ill, and because we had very limited amounts of tests and very limited amounts of PPE, personal protective equipment, the gloves, the N95s, the gowns. So we did not test very many kids. So those kids who got tested probably were sicker, which would explain why they had the higher viral load. So the implications from both of these studies, nasal viral load does not necessarily mean that there's an increased risk of transmission, because we just saw it just doesn't seem to happen very often in that Australia study and the other studies. And then symptomatic preschoolers, if they have higher viral loads, then we should follow the symptom screening recommendations, which will break the transmission cycle and keeps them out of school until they're no longer symptomatic and have probably tested negative. So even if you say, oh, these symptomatic children, they're going to have higher virus, as long as we follow the recommendations, which are sensible recommendations, then we'll actually avoid transmission and avoid infections coming into the childcare setting. Next slide. So there is this question though, why would younger children not transmit as efficiently? I just presented all this data. Children don't seem to transmit it as efficiently, 0.3% in Australia. There's a couple things. There's not actually great science that proves this, but there's some possible mechanisms that are probably useful to say out loud because of the implications they have around behavior. One is that young children have smaller lungs, and so they just don't puff out as much air. They don't puff out. If they have virus in them, they're just smaller clouds. They tend to have, as I mentioned before, less severe disease, which means they don't cough as much, which means they're not spreading it as aggressively with it coming out of their body, and so there's less spread. And then the really practical point, children are shorter than adults, and we know that most of the transmission of SARS-CoV-2, the virus that causes COVID, is via respiratory droplets. Those things come out when you cough, when you sneeze. And gravity pulls those respiratory droplets down. So if you're a child and you're coughing or sneezing or whatever, it's just unlikely that it goes up because you're just shorter than adults. And so those things are probably most of the reasons why there's not as much transmission. And you can see this picture. You're going to see it again actually on the next slide deck because it illustrates so nicely sort of what that looks like, that infection potential. Next slide, please. And just a few pieces of data about what we know about cases in childcare settings in California. So there are a total of confirmed infections in California, 739,527. The childcare associated infections is a small fraction of that, 2,376. And to date, the childcare associated infections comprise less than 1% of California's total infections. And these are data that are actually kind of similar to what we see around the country. They're lower here than in other places that have opened up more and have not had social distancing safeguards in place as much, such as Texas. They had a lot of cases. What is helpful to remember is that cases can happen in the childcare setting because they come from outside. Either an adult person walks into the childcare, the staff member, and might have COVID, or a kid might have COVID, bringing it in, and that would reflect community prevalence. What we really are making sure we don't want to have happen would be transmission within the childcare settings. These numbers don't tell us anything about that. Next slide, please. And this slide just highlights that adults in California comprise the majority of childcare associated cases. You can see that there's mostly it's staff and parents, staff in the gray and parents in the green, a relatively small number of children compared to that 22% or 23%, both in childcare centers and in family childcare homes. Next slide, please. And then I wanted to highlight the experience from Rhode Island over the summertime to help us think through, okay, how are we going to make this work? And this is a study. They looked at open childcare or summer care programs from June 1 to July 31st, 666 programs, almost 19,000 children, ranging in age from 0.5 to 12 years old. They only had 52 cases in the whole group, 19,000 children and lots of staff, which is about 0.3% of people. Their practices led to closure of 89 classes and quarantine of 687 children, 166 staff members, which is actually a pretty large impact. The cases increased as community prevalence rose. The thing to highlight, if you look in the what did they do box, it's helpful to think about what were these practices that, they had very few cases. So what happened? Stable pods of 12, and then they increased to 20 about halfway through the summer. They had separate spaces, no intermingling, which many of you guys are familiar with that idea. Universal masking of adults, but no requirement for children. They did daily symptom screening and enhanced cleaning and disinfection. And then the classes were closed if they had a symptomatic person. So that's a pretty high bar. Classes closed if symptomatic, not, that's the sore throat, runny nose. We know that happens all the time. Most of the guidance in California says you wouldn't do that for just a symptom person. You would do it for a positive case. So that's probably why they had such a large impact of the closure of 89 classes and quarantine of so many people. Next slide, please. And I'm sorry, just to highlight the end of that slide is to say, they had very low case rates. So we know how to do it right, actually. All of those good public health principles, those are the things that we know from California Department of Public Health, from our local public health departments, that's what to do. But here's the summary. Our current data suggests that children appear less likely to become infected or to transmit SARS-CoV-2 infection than adults. Childcare centers with children less than 5 years of age don't seem to be major drivers of transmission, particularly in low prevalence areas and with good mitigation strategies in place. And by mitigation strategies, that's those things that we just talked about: masking, physical distancing, or cohorting if you can't do the physical distancing, hand hygiene, ventilation, etc. But the risk of transmission is not zero in any age group, so that's why we do the mitigation. And transmission will likely be harder to contain if they're high prevalence settings, especially from asymptomatic individuals. And then key mitigation strategies will be a core part of our reopening. Next slide, please. So this is just a visual of what are our strategies, and you're going to hear a whole lot more about them in just a few minutes later on in this session. But I like to think of it as a layering approach. So stay home from when you're sick and screen people for symptoms. We talked about how that is an important piece of the story. Masks, 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 masks. We know that there's adult-to-adult transmission, and a mask really, really can help prevent that. It actually protects not only the other person. If you're wearing your mask, it protects the other person, but it actually protects you. And that's newer data. And they're actually going to start changing their sort of tagline. My mask protects you, your mask protects me, my mask protects me too. So that's really important. Wear those masks. Adults practicing good physical distancing, like I said, in break rooms and when you're relaxing, making sure that you remember that piece is important for you also. Wash your hands before touching your face. Symptomatic and asymptomatic testing are part of the layer, and then reducing the number of contacts, which is why those small stable cohorts for the kids is really helpful. It actually just reduces the risk of transmission. And also if there is a case, if you close down just that cohort, it doesn't affect as many other kids. Next slide. Okay, Dr. Ruel.
Thank you, Naomi. So we wanted to spend the final portion of this session turning now to consider the health of infants who become infected and to review what we know about this. Here we are now in August. Next slide, please. So I'm going to tell this story a bit as it has unfolded for us since the beginning of this pandemic. The first reports coming in January and into February were all focused on adults. Into March, we began to hear some reports from China that some children were being infected, but everyone was struck by the small number of case reports coming around children, but we didn't really have any good systematic studies as of yet. In early April was the first time we had a report about children in the US, and it really confirmed what had been suspicions to that point from the reports in China, which is that it looked like children were having a similar disease to adults, but really just much, much more mild. So similar spectrum of symptoms with fever and cough, but greater numbers that were asymptomatic. In this report, it was 18%, but of course now we really think it's more, even over half, but really just did much better. And this was the first report from the CDC in April. Next slide, please. But soon thereafter, literally later in the same month, we began to hear of a different kind of syndrome that children were presenting with. These first came from reports in Italy, and then the UK, Spain, and France. And early on, there were different names being floated around that you might have seen in the press. It was called hyperinflammatory shock in some cases, pediatric inflammatory multisystem syndrome, or PIMS. And then it's become more commonly called or referred to now as multisystem inflammatory syndrome in children, or MIS-C. Next slide, please. This syndrome looked very different from the syndrome that had been seen in adults. It seemed that some kids may have gone the path of the mild adult syndrome, but others went down the path of this MIS-C, which was characterized by a full body kind of systemic inflammation. So you can imagine your body, the same things that drive fevers and drive rashes with some infections, if really kind of taken to extremes, can cause inflammation of other organs in the body. So these children would get, in their worst case scenarios, inflammation of their mucous membranes, so swollen mouths and lips, skin changes, problems with their lungs and liver. In some cases, they'd get a headache or something like meningitis. In a really concerning cases, inflammation of the heart, leading to low blood pressure and problems with the heart, blood vessels. So this raised a lot of concern, of course, and they saw that this was coming after the waves of infection that would go through a community. So several weeks after, kind of helping us understand that this was more like a post-infection reaction, not so much the virus causing direct damage. But at the end of the day, it's more complicated and we've learned a lot more about it. However, if you go to the next slide, please. Still, it seems children get this very rarely, and it leads in most cases to very little harm in them. The treatment responds to the supportive treatment that we had been offering, and children in the end have done very well. So this slide now turns back to our population for this talk, which are children less than 5, and in this case, the information is around less than 12 months of age. And you can see in this study from studies from the US, The cases reports of infants have been, again, this very, very mild disease with fever, runny nose, cough, or even nothing. In exceptional cases, you see this cardiac inflammation, but now we're talking 1 or 2 cases in all the literature for infants that are really young, less than 12 months. And then in the survey of across the United States, and that included 500, it was only 4% that had this MASC that were less than 1 year of age. So again, we're in this place where we could say, oh, we don't have a lot of information about it in infants because there's so few cases reported. But the reason is, it's a good news reason. Here we are in August. The reason we haven't had large case series is because there aren't that many getting sick. They really don't get any of these scary syndromes that much, and they don't have to go to the hospital. So we're not getting these big case series that we've had with other age groups. Next slide, please. So turning more to that point, I think it's useful to step back and say, well, we now have information, epidemiologic information about how many cases we're having across the US. Now almost 8 or 9 months into the pandemic. So I'll just spend just a couple minutes on this and we'll turn to questions. So next slide, please. So these data are now assembled from the American Academy of Pediatrics and a Children's Hospital Association that pull information from across the US. And I'll overlay these with the CDC data. But this is reporting from 49 states. That includes New York City, the District of Columbia, Puerto Rico, and Guam. Turn to the next slide. So you might have heard in the news recently that there is a pretty striking increase in numbers of cases in children. And this slide kind of goes somehow opposite to how I usually think. It goes from bottom to top in terms of dates. So the most recent being September 3rd up top. And you can see that the cases per 100,000 children have gone from 13 to 680. But I think it's important to remember that this reflects 2 things. This reflects spread of infection for sure in the United States, which has happened over this time, but also the fact that we're getting better testing of children. So the real question is, well, now that we know more children are getting it, has this really translated into increasing hospitalization rates and increasing deaths in children? Next slide, please. And the answer is it hasn't. You can see here the hospitalization rate over time has remained really, really low and just nothing compared to the hospitalization rate in adults over 18 and really looking all inclusive. Next slide. And then here's the information about death rates across the United States. So just to turn to the table on the left, you can see these are all the deaths reported to the CDC as of August 29th, so the full 7 months of reporting. Across all ages, there have been a tragic number of deaths, over 170,000 attributed to COVID-19, and that's across the entire population of the United States of 300,000. But you can see that for infants under 1 year, there have been only 18, which is just a tiny number. Children 1 to 4 years of age, 14. These numbers are just merely a blip on the big picture, and usually are related to other kind of complicated illness. And just as a frame of reference, I won't go through them all, but you can see the leading causes of death in the US on the right. Again, that's for a full year, but even still, those numbers are way higher than anything seen from COVID. So really, infants and children are not, thankfully, very, very rarely dying from this illness. Next slide, please. So where does this leave us? SARS is not just a respiratory virus. We've learned that it affects multiple systems, but primarily through inflammation. And there may be there are short and medium consequences, and there may be long-term sequelae. We're going to have to learn more about this. But it seems clear that the signal we got at the beginning remains true, and especially true for infants, that children get illness far less frequently than adults, and the disease is more mild when they do. I believe that's my last slide, and we have a few more minutes for questions here.
Great. Thank you so much for that comprehensive presentation on a complex and evolving topic. We have some time to answer a few questions that came in ahead of time, and I'm just going to quickly introduce our Q&A moderator, Dr. Sohail Sood, who's a UCSF Associate Clinical Professor of Pediatrics and cares for newborns and hospitalized children at Zuckerberg San Francisco General Hospital and Washington Hospital in Fremont, California.
Thank you, Anda, and thank you for that picture of times when I had a little bit more going on top of my head. I suppose I'll just add on to this kind of introduction that I'm also a dad to 2 wonderful girls and a son to an amazing mom who taught preschool for 20 years. So it's with these perspectives I have the honor of asking our panelists a few questions. Thank you, Naomi and Ted, for providing us with an understanding of the what we know and what we don't know about how this virus is spread. And my first question is to you both to get a broad sense of your overall confidence in the evidence. One of the main differences, as you know, is that in the U.S., early child care educational settings reopened much earlier than other educational settings for older kids. Schools are still closed in the majority of this state, and I think you mentioned that there are more than 33,000 child care facilities open. So since these settings have been open for so long, here and abroad, if early childhood education settings were a place where many people are getting and spreading COVID, do you think we definitively know by now? And then maybe I'll turn that over to Naomi.
Yeah, sorry, I was checking if I was muted or not. I think our experience to date is very reassuring. So I would emphasize that the mitigation strategies are key, and people have really, to the extent they're following those practices, I think that's a lot of the explanation of why there aren't as many cases happening in preschools. I think it's important to say out loud, because people watch the numbers in the news, the cases do go up over time because our prevalence in our communities are going up over time. So as we go through our second surge, you will see increased cases. But I think the question about transmission in the preschool setting and in the childcare setting is really the most important piece, and we're not seeing a lot of transmission. So that is good news.
Great, that's good to hear. You think the evidence is pretty strong. But of course, as you've mentioned, and both of you have mentioned, lower risk is not zero risk. And with that in mind, as you know, kids this age learn and live through touch, right? They slobber on objects, they put everything in their mouth, they share toys, and relatedly, parents and providers interact with these kids in a very physical way. They change diapers, they hold someone's hand when teaching them how to write the alphabet or use a glue stick. So how concerned should we be about transmission through touch? And maybe I'll ask Ted that question.
Sure. I think as you kind of have framed it, I mean, I think we've learned more as time has gone on. Early on, you remember the first studies showed, well, that COVID can live on a steel banister for 48 hours. And there was a lot of concern that it could be spread by multiple mechanisms. And we have seen reports of this transmitted by touch and by things. But it does seem to date that really the primary mechanism is by droplet. It is by what leaves our mouth and then what ends up in people's mouths and their eyes. Now, I'd say hand hygiene and making sure you don't touch things and then touch your eyes is probably the key thing. It's not so much that it's on the box from the UPS guy. It's going to be on, but it could be on something that you are touching right after someone has coughed and you're putting your fingers in your eyes. So I think we are confident now that that the measures that we are implementing are very good. Even if they're not perfect, we're going to get cases. We're going to get cases in some of these early childcare settings, but we're doing a great job reducing them. And if you remain attentive to the core strategies, that you can really do a good job of preventing infection.
And I'll add that I think preschool and daycare providers are actually pretty awesome about knowing how to keep their hands clean. I think better than maybe other teachers would be, because they already know about this. And so washing hands after diaper changing, all that, I think that comes to second nature in many ways.
Excellent, thank you. And then maybe I'll ask this question to Naomi. So news reports come out every day that at first glance seem concerning, right? There are outbreaks, quote unquote, in daycare, schools are being closed. Given how well versed you are in understanding how this virus spreads, I'm curious how you read the news. And when new information comes out, do you have any tips for folks who are not experts to think about how, think about what we're reading?
Yeah, I think probably the three top things that I recommend to people is, first of all, thinking about what's the sample, what's the universe of where those cases are happening. Like that one about the super spreaders, that was really sick kids in the beginning of the pandemic. So that's probably why that study showed what it showed. So that's the first question, is what's the population? The other question is it just telling us about cases? And that's about community prevalence, which we know it's rising, and therefore it's why it would be rising in kids. Or does it tell us something about transmission in the setting that we're worried about, schools or early childcare centers? Most of the time, many of the news reports are actually just about about cases and they don't tell us about transmission. Some of the studies can tell us about transmission. So, you know, if you see a new study, then that's something to be thinking about. And then the last thing to be thinking about is just making sure that you sort of feel like you understand the you know, where things are coming from and who your population is, can really help you interpret that. Particularly what I'm always looking for is like, do we learn something new about mitigation, like masks, physical distancing, et cetera? Most of the time, most of those things, Georgia camps, I don't know if you guys saw that Georgia camp thing. Many people worry about the Georgia camp thing where there's a lot of transmission. It was some of the younger kids got transmission. It's because they didn't do the basics. They weren't masking. The kids did not mask. They were indoors. They did not have open windows. It was poorly ventilated. They were singing and shouting in indoor spaces. Those are great ways to transmit. And so we learn from that what not to do, rather than, oh my God, we can't reopen because people are going to pass around.
Great, thank you. So many more questions, so little time. So for now, I'll transition back to Anda to introduce our next speakers. I think Dr. Bardach needs to drop off, so we sincerely thank you for your time. But there'll be space at the end to ask more questions to Ted and all of our other speakers.
Yeah, and I'll stick around for a few minutes just to do, I'll do asynchronous Q&A if there's anything left in there.
Thanks so much. So our next speakers, we are going to hear about the science on safe health practices in early care and childcare settings. And our speakers are Dr. Abbey Alkon and Bobbie Rose. Dr. Alkon is a professor at the UCSF School of Nursing and director of the California Childcare Health Program. She's a pediatric nurse practitioner and an epidemiologist with clinical and research experience designing and conducting health and safety interventions in childcare settings for over 20 years. She's a national leader in the field of childcare health consultation. And Bobbie Rose is a program director for the California Childcare Health Program and is a public health nurse and a childcare health consultant with over 15 years of experience working to support health and safety for children, families, and the early care and education community. She directs the statewide preventative health and safety training of trainers and technical assistance program and has developed many informational and educational materials on health and safety topics for the childcare community. Really grateful for your expertise and for taking the time. Thank you. Abbey and Bobbie.
Hi, this is Abbey. Can you hear me?
Yes, great, thank you.
Next slide. Well, we're going to shift our focus a bit and talk about safe practices. So we've heard a lot about that this is a new virus and that we're learning new information every day. As both Ted and Naomi said, we know that it's transmitted by aerosols and droplets in the air. So we're going to talk a little bit about how do we translate that into practices in childcare. We do know the virus settles on the ground or on surfaces. So we also will talk about some cleaning and disinfecting. But we do know that the most important thing is to think about aerosols. And we want to reduce the spread of the virus. And so the way we think about that is we want to reduce the spread, but we know that we can never 100% stop the virus from spreading. So we always need to be prepared. And in childcare, we have a lot of procedures and protocols. And this is what it really calls for, is thinking about how do we prepare for a positive case of COVID if it were to happen in our childcare program. Next slide. I just want to pause to say that if we can change the video, that would be fine. I have my video on now. So in childcare, as we know, we look at best practices, standards, and regulations to really guide the practice that we have. And we look to the CDC for guidance specifically during this time of COVID. And as we know, it has been updated many times throughout this pandemic, which has been really helpful. In the beginning, it gave us guidance for childcare just for caring for emergency workers And now it's really changed to focus on reopening childcare. Caring for our children, which is our national standards on health and safety, has always been a guidance for us in childcare. It's been really helpful in many of the guidelines that we're looking at right now for this pandemic. The Environmental Protection Agency provides helpful information about disinfectants. Our California Department of Pesticide Regulation has some wonderful information, and we'll share with you some of the posters that we'd work with them to develop on cleaning and disinfecting. Of course, the Department of Social Services, California Childcare Licensing has regulations, and as you all know, they've been updating and changing things as we needed them during this pandemic. The California Department of Public Health and our local public health departments have been so critical during this time. And California OSHA has been also helpful in providing guidance along with the health departments for our workers. Next slide. So this is a slide that sort of shows the same information that Naomi just talked about, but I wanted to really reiterate this again, that what has been really interesting in childcare is we know in California, in childcare centers, they are mandated to report positive cases of COVID. It doesn't mean that they're transmitted there, but this is a wonderful place to get information and to share information. So it goes to licensing, it goes to our public health departments, so they're able to share the information and have it more public. And what you can see here is in this pie chart, is about 18% of all of the cases reported in childcare were of the children. So although there has been some big headlines about large numbers of cases of COVID-19 in childcare, it's actually that's where the reporting is going on, but the most of the cases are parents or staff, and so it's mostly the adults. Next slide. And here we break it down a little bit more in the next slide, in comparing childcare centers and family childcare homes. So you'll see the darker red is childcare centers, the lighter red is family childcare homes. And just starting on the left, you can see that the number of staff, there were more staff in childcare centers compared to family childcare homes that had positive COVID cases. Parents, it was quite similar. Children, it was also quite similar. So we do know that there are some differences about centers and family childcare homes. And the important thing that we know is that stable groups and small groups are important, and many family childcare homes have always had those practices of small groups. So there's less exposure, and if there is a positive case, it's easier to isolate. There also has been some new data in San Francisco Chronicle that was just the other day in September 5th, and also trying to give some perspective on the number of cases in childcare. And in Alameda, they were saying there were about 3 cases per 100 facilities. And in Santa Clara, it was 5 cases per 100 facilities. So the numbers, as we've been hearing tonight, are not that big. They're low, but they are there. So we still need to really be aware and think about what we can do. Next slide. So this is a big graphic that I found really interesting, and I think it really shows that our focus on reducing the risk of COVID has many different dimensions. And what we see on the left-hand side is there's different ways of thinking about how do you mitigate or how do you reduce our risk. It has to do with face coverings. It has to do with the amount of contact time. And on the very top, across the top, it has to do with occupancy, having low occupancy, smaller groups of people versus high occupancy, and then ventilation. So we have a lot of different information here, but what we can see is the green means that things are okay. The red is you're really at high risk. So the high risk on the bottom right is if you're in a poorly ventilated place, if you're not wearing a face covering, if you're speaking, if you're shouting, if you're singing, this is going to be the most high risk. Then we go over to the green area. This is where you have smaller groups, low occupancy. Ventilation is important, but more important is wearing a face covering and having a short amount of contact time. Being silent, not talking, which is not that common in childcare. Speaking, we hope, is very common in childcare. And shouting and singing is something that we're not doing as much, but if you have a face covering, if it's a short amount of time in a small group, here it's in the green zone, meaning that's okay. So most of what it's saying here is that face coverings really make a difference because those are the first 2 rows, and that's the green area. And as Naomi had mentioned, the speaking, shouting, singing does make a difference. And as we know about in the story about in Georgia in the camp, there was a lot of singing without face coverings. So that made them go into the red part and be more at higher risk. Next slide.
Okay, hi everybody. I'm gonna jump in here now. Hello. One of the points I'd like to make at this point is that many of the practices that are successful in reducing the risk of cases in childcare are very familiar practices to all of you. I think that's one of the reasons that childcare has been successful and that you all have been nimble and flexible is because many of these things you're doing already. So things like communicating with families about health issues, having a daily health check, covering coughs and sneezes, you know, sneezing into your elbow, having stable groups of children as small as possible, excluding children for illness, washing your hands regularly. That's a everyday thing, and regular cleaning, sanitizing, and disinfecting. Next slide. So then there are some practices that are less familiar and some seem honestly downright strange. So starting with the limited entry into the facility and limited physical contact. Normally parents sort of come and go, and you might be having tours of your facility to bring new families in. The limited physical contact, like no hugs and no shaking hands, no high fives. All of this is feeling a little bit like a strain, and is one of the harder things to cope with right now. Newer attention to ventilation and fresh air, especially these days when the outdoor air quality has not been very good. The 6 feet of distancing, things like, you know, having to rearrange your furniture and whatnot to create more space indoors. Health screening now includes taking temperature, so you know that's new. And of course wearing face masks, that's very new, and it's a very hot topic. There's always a lot of questions about that, and that's why there's a little flame next to wearing face masks there. Next slide, please. So Naomi and Ted talked a lot about how the virus can spread the most. And we've sort of on this table divided the way that it can spread into 2 groups. So air, which we know is the most effective way for the virus to spread, and surfaces, which is also possible. So all of our practices sort of fit into reducing the risk of spreading in one of these 2 ways. So for example, the health screening, keeping children outdoor ill, physical distancing, smaller groups, limited entry to the building, face masks, more fresh air and outdoor time. Those are all strategies that work to sort of reduce exposure in the air. Now the surfaces, that's going to be things like, you know, hand hygiene and cleaning and disinfecting and gloves, and to a certain degree limited entry to the building, and keeping children and adults out who are sick. So we're going to go through some of the strategies in a little more detail. And so at this point, I'm going to turn it back to Abby. Next slide, please.
Oh, Bobbie, you're going to continue. I just lost my internet. I'm sorry.
Okay, I'm going to continue. Okay, so one of the main strategies is the daily health screen. So this poster that you see on the right, we've had as one of our posters on our website, and people have used honestly across the state and across the country even for years and years of looking for signs of a child being ill when they come in the morning. So you want to use all of your senses, you look for signs of illness, you listen for complaints, you smell for any unusual odors, you talk to the parent about any illnesses at home with other family members, just general mood changes in behavior. But now we're also asking and even checking if a child has a fever of 100.4 or higher. So this is just, again, just sort of enhancing this regular practice. So now we're looking for more symptoms. So we're looking for fever, cough, shortness of breath, difficulty breathing, chills, repeated shaking with chills, muscle pain, headache, sore throat, congestion, runny nose, nausea, vomiting, diarrhea, new loss of taste and smell. So that's a lot. There's a lot of symptoms there we're looking for. And actually, many of those things can be other kinds of illnesses as well. So it's an enhanced morning health check. And again, we are just trying to keep children who might be ill out of the program so that the virus does not spread. Next slide, please. So this is just a chart that comes from the CDC, and it lists all the different symptoms and really the kinds of things they can be, including COVID. So here are all of our COVID symptoms on the left, and then the columns following that are things like strep throat, the common cold, flu, asthma, seasonal allergies. So as you can see, there's a lot of overlap, and it might be hard to tell. A child who has, sort of a baseline of a little runny nose because of, allergies, you might look at that when you're deciding whether or not that child can be there that day. But for the most part, you will be sending more children home with signs of illness than you might be otherwise. In normal times, we might not worry about signs of a common cold so much because children have colds so much. However, in these times, we are being a little more strict about who's able to enter the facility that day. Next slide, please. So if you are keeping children out, these are the criteria that you would use. So if they have any of those symptoms of COVID-19, if a family member has a diagnosis of COVID-19, if a child has symptoms of other illnesses that meet the usual exclusion criteria, and then if a child happens to become ill while they're in the program that day, then they would have to go home right away and make sure that there's a family member or backup to pick up the child right away as well. And it's also important that that child be wearing a mask and that they wait in a place that's away from other children, but still supervised, of course. Next slide, please. Okay, so one of the main ways that we reduce the risk of spreading illness of all kinds in childcare is hand washing. So we're just looking for sort of a higher vigilance of hand washing, but the steps are the same. We're still looking for 20 seconds and running water and just plain soap and just washing hands upon arrival and frequently throughout the day as needed. Next slide. What is new is that we're seeing a lot more hand sanitizer in childcare than we used to. So soap and water is still the first choice when available if there's a sink nearby, but there's not always a sink nearby. So you may find the need to have hand sanitizer on hand, and that's going to be for adults and children over 24 months. The product should contain at least 60% alcohol and should be used on visibly clean hands. So if your hands or a child's hands are dirty from playing in the sandbox or playing with Play-Doh, they need to be actually cleaned or the hand with soap and water because the hand sanitizer actually won't work. It should always be kept out of children's reach, and we've really seen an uptick in calls to the Poison Control Center on poisonings for children, especially for children under the age of 5. So watch where you're storing the hand sanitizer. And there was also an FDA warning that came out of some of the hand sanitizer products having being contaminated with methanol. And so there's a list on the FDA website that you can check that if that's one of the hand sanitizers that you're using. And just always remember that soap and water really are the first choice if available. Next slide, please. Okay, so now we're going to move on a little bit to cleaning and disinfecting, because this is another one of our strategies. So just to break it down a little bit, and for many of you, this might be review. So to clean means to physically remove the dirt, the debris, the sticky film by washing, wiping, and rinsing. Basically, we're talking about using soap, maybe detergent and water, and microfiber cloth. So we're just cleaning when we're just removing debris at that point. Disinfecting is taking it up another step. So disinfecting actually means using some product that is registered and kills germs, basically. So it kills, to disinfect means to kill nearly all of the germs on a hard, non-porous surface. Next slide, please. Okay, so these are a couple of posters that our program developed in partnership with the Department of Pesticide Regulation. And they're just some very basic infographics for childcare on step-by-step cleaning and step-by-step disinfecting. And it goes through each step in a very simple way. And it's a nice way to train staff so everybody's on the same page about cleaning and disinfecting and what products you're using and what steps you're taking. These posters are available in Spanish, and they're also available in Chinese. Next slide, please. So some things, it's adequate to simply clean them without that extra step of disinfecting. And always remember, any surface that you are going to disinfect, you need to clean first anyway. So always use cleaner soap and water on things like toys, bedding, floors, clothing and hats, cribs, cots, and mats, outdoor play equipment, and refrigerators, that sort of thing. Outdoor play equipment, as we were, I think we were discussing this earlier, that the CDC advice has actually changed on that. They were recommending disinfecting, but now just a simple cleaning with soap and water would be enough. Next slide, please. And what surfaces should be disinfected? So when we're thinking about killing germs on surfaces, we really want to focus on things that we consider high touch surfaces. So things like door and cabinet handles, surfaces that have been soiled with body fluids, toileting and diapering areas, and that includes the diaper changing tables and the diaper pails, and countertops in bathrooms, potty chairs, hand washing sinks and faucets, toilets, bathroom floors, that sort of thing. Next slide. When you're choosing a product to use, and when you're about to use a disinfecting product, please know that the label is the law. So that means that you should always follow the instructions on the label anytime you are sanitizing or disinfecting. Also look at the label for more information, like, do you need to mix the product with water? How long does the product need to be on the surface? That's also called the dwell time or the contact time. Is it okay, that's over there, to use the product on food surfaces, or do you need to rinse that product off if you use it on a food surface? So the label has a lot of information that will help you use that product safely. Next slide, please. Okay, so the label will also have an EPA registration number, and this is how you know if this is a product that is safe and effective as if used according to instructions to disinfect. Without that, EPA registration number, you cannot be assured that it's going to kill germs as you expect it would. So it's really important to look at that label. Next slide, please. Thank you. So there are safer choices that you can make as far as what product you choose to disinfect. And some of you may already know this if you've been participating in programs through your city. I know that San Francisco had a big program to promote safer products, and also Alameda County did as well. So we want to make sure that we are using products that are as safe as possible around children, and also for staff health as well. Now, the Safer Choice product program through the EPA sets standards for products and active ingredients that are safer for human health and safer for the environment. And also our advice, our guidance that came from our state agencies in what people are calling the Blue Book, the guidance that's from CDPH and licensing in Cal OSHA. They recommended the top 3 on this list: the citric acid, hydrogen peroxide, and lactic acid. Ethanol and isopropanol are 2 alcohols that also can be safer to use, but there is a little bit of a safety issue around flammability. So if you're buying it in bulk, you might want to really be careful about where you're storing it. But for programs that are not buying so much at a time, that would be less of an issue. There's also a list on the EPA website that is called List N. And those are the products that meet the EPA criteria for use against COVID-19, the virus that causes it. So, so you can go onto their website and you can put the registration number into the little search engine there, and you can make sure that the product that you are using is something that is effective against the virus. Okay, next slide, please. So why do we care so much about choosing safe products? And this is just about children being more vulnerable. So children are more vulnerable to exposures to chemicals and fumes because they're growing and they're developing, and their little bodies have a harder time breaking down the toxins. They breathe twice as fast as adults. They have softer, more absorbent skin and smaller airways. They spend more time on the floor where chemicals can collect in dust. And some products are actually potential asthmagens or can trigger asthma attacks in children and adults. Next slide, please. So again, I'm back to the label. So again, take a look at that label and see what ingredients are in the products you're using. There's one example on the left, and that is an example of a quaternary ammonium. The one which is perhaps a less safe active ingredient. It's more of an asthmagen. And the one on the right has the active ingredient of hydrogen peroxide, which is on the list of safer active ingredients. Next slide, please. Okay, so let's move on to limited entry. Think about who's coming into your program to make sure that you don't have a lot of extra people there. So that means things like classroom tours and volunteers may need to be on hold right now. Some people are doing virtual tours so that they can build their enrollment that way. If you have children with IEPs, with special needs, that can continue. Or if a breastfeeding mom wants to come in and breastfeed her baby before dropping the baby off, that also is a situation where you would want to allow that. But also keep in mind that refraining from hugging and shaking hands is a good idea with parents as they arrive, and also assigning drop-off and pickup times for small groups to avoid a large number of people gathering outside. Many programs have moved their sign-in station outside the facility, and they're doing their health screening right outside the door. Again, with the bad air, maybe that's happening less, and as the weather gets colder and rainier, we might be moving indoors, but luckily in most places in California, we can be outside most of the time. Next slide. So our stable small groups are going to be a key way to keep transmission down. So keeping group sizes as small and stable as possible. Children and staff shouldn't change groups or mix groups. If possible, having a group have their own room, and keeping siblings together if possible. I know that enrollment has shifted a little bit. Some children's siblings who might have gone to kindergarten this year or even first grade might be staying in the child care setting or the preschool setting because the elementary schools have not opened yet. So if you can keep those siblings together, that decreases the risk of transmission as well. Next slide. When it comes to infants and toddlers, it's really not possible to care for infants and toddlers from a distance, as you can imagine. So we learned earlier that infants are really not transmitting much disease and aren't getting more sick, but babies in general are more vulnerable if they're sick. Make sure that you provide the clean smocks for staff so that if they get body fluids or secretions on, they can change easily, and staff should be wearing PPE. Then that would be a face mask and a smock. Of course, infants and toddlers under 2 years old would not be wearing a mask because of risk of suffocation. Next slide, please. So fresh air, when we have it, fresh air is very healthy for children. We know that children are actually more physically active when they're outside as well, which is healthy for them. So maximizing outdoor play and activities that include fresh air, but we always have to consider the air quality index. And when you're doing that, just sort of plan your activities so that there's less physical contact, less sharing of equipment, less things like waiting in line. Some activity ideas include physical adult-led activities like doing the hokey pokey or playing Simon Says, follow the leader, freeze dance, obstacle courses, and such. Just, you know, child care providers are so clever in coming up with great ideas and sharing them with each other that I'm sure there will be more ideas to do that in the future as well. Next slide.
So due to time, I'm just going to have Bobbie go a little bit faster and we'll go quickly through the end.
Okay, good. We've already seen this infographic, so I'm just going to skip through that one, but just to say to repeat, wearing masks is really important. Next slide, please. Some do's and don'ts about masks. So make sure you can breathe through it, wear it whenever going out in public, make sure it covers your nose and mouth, wash it after you're using it. And again, it's not for children under 2 years old, and N95 masks and such are for healthcare workers. Next slide. So some tips for effective masking: wash your hands before putting the mask on and after taking it off. Make sure that the mask fits securely under the chin and against the sides of the face, and be sure that the nose and mouth are covered. Next slide. And Abby, are you able to jump in on this slide?
Yeah, we just want to invite you to come to our website and see our homepage. We've changed to COVID resources, so please use the California Childcare Health website as much as possible. And lastly, we just want to thank everybody for the great work that you do as childcare providers and administrators and caring for children. So thank you so much.
Great. Thank you so much, Abby and Bobbie, for this helpful and practical advice. We're running a bit behind, but that's okay because you're giving so much great advice. And so I'm going to ask you one question, and then hopefully if you guys have time to see whether you might be able to address some of the other written questions that are coming through the chat over the subsequent remainder of the presentation. And that question is about masks. We are getting so many questions about masks. And so we'll make it a two-part question, but part one is, who do you recommend actually wear one? And I'm talking about the children. different agencies and bodies. Some are saying where, you know, over age 2, everyone should wear a mask. Others are saying you can say over age 5 or an older age. So who do you recommend wear one? And then the second part is, even for those for whom it's recommended, we know in this age, I can speak from personal advice, in this age, it's never going to be perfect, right? And so how hard of a line should a child care provider or a parent draw when it comes to enforcing the use of a mask? If a kid's throwing a tantrum or trying their best but still taking it on and off, what should we do? And maybe I'll direct that question to you, Abbey.
Sure. This is a great question. So number one, masks should be worn by providers, and there's no doubt about that. And I think that has actually been our practice for quite a while, and that has been a strong recommendation. Now there's been more recommendations about children's wearing masks. And as Bobbie said, children under 2 should not be wearing masks. Children who cannot put on and take off the mask themselves safely, and some children with disabilities or special health care needs should not be wearing masks. But we are seeing more children being able to wear masks, and what we feel like it's a team effort. It isn't the kind of thing that you walk into childcare and all of a sudden the kids are going to be able to wear a mask. We ask the parents to be a part of this and to help. If children start wearing masks at home, seeing their parents as role models wearing masks, thinking of masks as new and other healthy habits, it can be something that's integrated into their everyday life, just like brushing their teeth and doing other things. We also know that masks are not going to be worn during meal times and during naps. So there is some time for relief. We also know that if you have masks in childcare, you need to think about safely, where do you put the masks? Where do you store the mask when they take it off? And to wash your hands before and after using your mask. We also think it's a good idea to ask parents to bring in a few masks every day for the children, because as you know, it could get soiled, it could get lost. And so they'll need to have an extra mask around. So those are just some thoughts. Bobbie, do you have anything else you want to add to that?
You know, I would just add to take a positive tone that is matter of fact, and you know, avoid scolding children. Of course, they're learners, and that you know, child care providers and preschool teachers really are always helping children interpret the world around them, and this is just part of that. So yeah.
Perfect. Thank you. Thank you so much. And I'll transition to Anda.
Great. Yes. Thank you. So we thought that, you know, after all this information, and I'm sure there's so many questions still, and so much information we received, that we thought that it is super important to have us close with stress and coping and stress and resilience in early care and providers. And so grateful for Dr. Cheryl Williams-Jackson, who's a full-time professor in the Human Services Department at Modesto Junior College and is faculty with the West Ed program for Infant and Toddler Care Institutes. She's also a mental health therapist and previously served as an early childhood mental health consultant for Alameda Family Services. She's taught child development for over 20 years in higher education. As the CEO of WJ Developmental Consultants, she continues to support early care and education organizations in integrating diversity, equity, and inclusion best practices, trauma-informed strategies, and intentional self-care into the work environment. So, Dr. Williams-Jackson, please take your full time in the presentation, and we'll adjust the Q&A on our side.
Okay, wonderful. So thank you so much. And I want to also start off by saying that I am a parent of 2 adult daughters. I'm also the grandmother of 6 grandchildren, ages 1, 2, 3, 5, 6, and 7. So just know that this topic that I'm talking about, it is very dear to my heart, but also what I've been hearing so far in the sessions. For me, information is one of the best ways to help us with beginning to find a way to pretty much deal with what's going on right now. We're being challenged by, you know, so many disasters, you know, here in California with the pandemic, but also with the fires. But we also have community crisis that is taking place, as well as every family has their own crisis that is going on. So there's lots of stress and learning how to cope with the things that are taking place. So on this first slide, these are just two of the questions that just came in this week to me. And so every week I'm getting lots of questions. And it's because not only do the family members have questions, but also the children have questions. And children, as you know, they have their ways of asking questions or pretty much saying how they are experiencing the stress that is going on. So the second one at the bottom, where my daughter tells her teacher every day that she feels sick and wants to go home, what should I do? And first we have to talk about, well, what's going on with the child. Children handle their stress in a very different way than adults. So a child who's calling or saying that they want to go home off is actually letting us know that something else is happening here. And as the adults, we have to slow down and acknowledge what that child is trying to communicate to us. Next slide. With that, I will say that we all have mental health. So everyone has mental health. Everyone has where we're having to look at, how are we handling things that's taking place when it comes to our psychological health or our emotional health, and how are we socializing with each other, and what does that look like? And so mental health we all have. Some people have diagnosis of mental illness or undiagnosed mental illness. So when we say that, mental health, we have to take care of our mental health, even more so right now, we have to think about how we are experiencing the things that are taking place in our environment. And do we have the resources available to help and assist us? And sometimes the resources may be individuals that are in our life that we can talk with, but it may be those that we haven't introduced yet, like for instance, mental health care. We're fortunate that some programs are able to have early childhood mental health consultants. And so when teachers contact me or when parents or families contact me, what I do is I check to see if there is an early childhood mental health consultant available for them to talk with, to learn how to breathe, even just breathe, but to learn to find ways to understand what they have in their within the system that they're in, to help them to learn to cope with what's going on. So mental wellness, we all need a mental wellness plan, whether that plan is written or whether we've thought about that plan. I try my best to get people to write out their plan, what their mental wellness plan is, only because when we become extremely stressed, it's really hard to begin to think about and to plan for ourselves, what do we want to do, and what is available for us to be able to take care of ourselves when it comes to our mental health. Next slide. So we have to think about, when it comes to stress, the first question is, how do you hold your stress, but also how do your children hold their stress? And even as teachers, how do the children in your environment hold the stress? How do you hold stress as a teacher versus how you hold it as a parent? Because it can be very different, because you may feel more anxious when it comes to your own children, whereas you may have more resources available to you when you're in the school, within the classroom. So, and then you may be worried about your own children who are going also to childcare or in school as well. So we have to look at the fact that we are holding space as teachers. We're holding space for more than just ourselves and our family when it comes to, how we're taking care of them and how we're taking care of ourselves. So we really have to do things a little bit different, meaning that, and I see this all the time, it's not business as usual right now. So it means thinking outside of what we are used to doing, and increasing how we're taking care of ourselves. And remember that stress, what we're talking about with stress, and especially extreme stress, is that something is coming at us and it feels like we do not have in our capability the skills to cope with what's taking place, and something new has to be introduced. And whether that something new is a professional or just something new being introduced that we can implement into our lives. So we really do have to take a moment and think about, if we are stressing, is it affecting the quality of our life? And when I say that about the quality of our life, what I'm talking about is if you're having a hard time getting up out of your bed to go into work, and it's getting harder and harder to do that, that we not just dismiss it, that we at least acknowledge that, yes, it is getting harder and harder. Because if you had an illness, you would name that illness. You know, if you had a cold, you had the flu, you would name it. However, when it comes to mental health, we don't name it. We just say, I don't know what's wrong with me. I can't seem to get up, and I can't get to, you know, I'm not feeling like I normally feel. So we have to name that maybe we need a moment and to take care of ourselves and to take care of our own mental health. So one of the things I try to get individuals to do is to acknowledge where your stress is taking place. Where are you feeling it in your body? But is it taking place at a certain time? So if your stress, most of your stress is coming up when in the morning when children are checking in, because you know that maybe you have children when you're doing their morning check, that the children tend to grab you and give you a big hug. And so now that stresses you out because you're not sure, how do I handle that? One of the best things for us to do is to talk to other teachers to see how are you handling the check-in. And if it's not other teachers in your program, finding other teachers around, or even that are in other programs, or some of the meetings that we have where those discussions, those types of things are coming up. We didn't have that yet, have to have that conversation yesterday. But yet today we're having to have that conversation about what are we doing to, you know, when these things that usually take place. Like for instance, we've already figured out that for check-in with the parents, that maybe we need to meet with them outdoors and they check in outdoors. But what else have we not talked about that may come up in your classroom space? So these are questions to ask ourselves in advance, but also maybe if it's taking place right then that you notice something, that it's not something that we say, oh, we'll figure it out on our own, but to look for your support system, including other teachers or other professionals or your coaches that are able to provide some input and some ideas. Because one idea for one person may work, or one program may work for one program, but not work for the other program. We know that children, you know, have various needs. You have some children who yes, they need a hug every day. And so in conversations, and I'm thinking of one program where in conversation and talking about 4-year-old and 5-year-olds who often want to hug a lot, and finding ways to create new ways that we hug each other. And whether that's like we do as adults, you know, we do this thing where we just show each other that we're hugging each other, or if there is an item that a child can hug, and at the same time the teacher is hugging that a different item, and we're saying we're hugging each other now. These are just things that I've heard other people have come up with that works for them. Now, even though I'm giving you that example, it may not work for your program or for you. And so it really is about having those conversations about how do we come up with other ways of doing these things that brought us comfort before. So for me, I love talking with my friends, you know, and especially my colleagues. But I realized that, you know, being in this new, the new business that we're in right now and how we're doing things, I realized I can't see them every day. So I intentionally have to create that space, meaning that right now it's Zoom that I created, but I create it and I say that, you know, let's meet on a certain day and we talk with each other on a particular day. So it's important for us to realize there's certain things that were in your life that brought comfort to you, that right now you may have to think of a different way of doing that. For those of you who are used to sitting and chatting with your colleagues, you know, just where you're just running across them and you're having those conversations with them, and now you're finding that you're spending more time in the classroom with the children. I want to say to you, it is important that you're in the classroom with the children. However, please remember that you have to take care of yourself. So those breaks that we normally just dismiss sometimes, right now is not a good time for us to dismiss those breaks. Those breaks are important for us to take because we're holding spaces in our hearts and in our thoughts for the children and families also, and that takes a lot out of us. So taking those breaks are within the system, and so we need to utilize them. Often one of the things that we may not think about as well is that our organizations, if the organization understands the importance of stress relief for the teachers, the system, meaning that the organization also has to make it a priority that teachers take care of themselves. There's a program that I was working with when they realized we were working around intentional self-care, and they realized that they did not have a space that was relaxing for the teachers. So what they did was they found that space, and it was a tiny little space, but they took and they put some flowers in, and they took and they did something, and there was this agreement that when I'm on break, if I'm in that area, that unless it's an emergency, that area right now is where the teacher needs to just kind of debrief, kind of breathe, and take some time. Right now, that is an important piece in their life that needs to take place. So the question again to you is, where are you holding your stress? How do you hold that stress? So where is it taking place in your body? To be able to acknowledge that, and that includes writing it down somewhere and not just keeping it in your head that when I start feeling the strain in my arm, that I'm just going to dismiss it. Instead, acknowledge that that's something that's taking place that you actually need to take care of. And maybe that's just that you need to stop, breathe, do something that you've put into your self-care, wherever you're keeping your self-care information. Remembering that there are different types of stress that we have, where it's physical, where it's in your body. If you're feeling back pain all of a sudden, indigestion all of a sudden, all of these things are happening. You're finding that you're tired. Your body is actually telling you that you're experiencing some type of physical stress. Emotional. I talk about worry. Worry, there's two different types of worrying that we do. One is the what if worrying. So it's kind of like that hypothetical worrying that we do, which is one that we can't really solve. So when we get in that place of thinking hypothetically, like what will happen if? And so our children already are in that place often, what will happen if I go back to school? Who's going to take care of me? Will the teachers be there, and keep me safe like you did, like you are keeping me safe? So those are those hypotheticals. Children will do that. But as the adults, we have to recognize when we're utilizing hypothetical worrying and begin to make a switch to more practical worrying, meaning that, okay, what does that worry mean? That if I'm saying, what if I go back to school? Instead, something we can solve is, I want to know if my children are safe. I want to know. And so I can ask someone that question, and they hopefully can give some information back to me. Here's how we're keeping your child safe. So we heard so far throughout this webinar that there are several ways that we are implementing to help our children to feel, or to make sure that the children are in places that will keep them healthy. So we have to explain that also to the families so that they're not stressing so much, so that when their children ask questions, they're able to answer those questions to their children. Remember how when when you're with teacher Bobbie, that she washes her hand and you wash your hand? Well, we will do that at home too, because the center has already had those discussions with them about hand washing. And so they're able to have those conversations. Another thing is, if we see children doing behavioral things, but even if the adults are doing things, like for instance, if a parent says, I don't know why my child cries so much now, they didn't before, chances are the child is crying because there's some stress going on. If it hasn't increased, I should say. But there could be other reasons why, but because of what we're in right now, we have to ask ourselves also, is this some stress that's dealing with the disasters and the crisis that we are experiencing right now? Nail biting, teeth grinding, and we need to actually ask family members, and it may not be on our forms when we are asking questions, but it may be an important thing that we do ask. Do you see any behavioral changes in your child, like if they're biting their nails, or they're grinding their teeth, or if their sleep is being disrupted, if you've seen any changes in their eating habits, or even social withdrawal? So right now, that's one of my worries right now, is that when we do go back full force into whether it's school, childcare, and many of your programs, you've already started that. And which means that we may see where there are some children who hesitate to walk through that front door. And mainly because the way that we have it set up now, parents are not walking in with them. So maybe one of the things that is possible is that we could have where the family members are getting pictures of what the environment looks like in advance, and they can have conversations with the children about, you know, when you go in, where do you go to play? And so they have pictures at home as well as they're seeing it in the classroom. And so that allows them some sense of, I'm getting to know the space, but I'm doing it with someone who I feel safe with, which is the parents or the family members. And so having those pictures. I've also shared before about, you know, having pictures of the teachers who are wearing masks, but also having a picture of what that teacher looks like without a mask in the classroom. The same thing we can do with children, where we take pictures of them with their mask on and with their mask off and put those in the classroom. So the idea here is to find ways to reduce the stress about these new items that are being introduced into the environment, such as, you know, we're not holding them as much, but also the fact that we have masks in the environments too. And then when we're seeing more what we call chronic symptoms, like anxiety, depression, sleep disorders, normally a mental health, like the early childhood mental health consultants can address that, because that becomes more than what we as teachers in the classroom should be having to try to figure out how to solve. So it's important at that point that we are able to find information from others who have a background in that mental health. And so I think more than anything that right now we really do need organizations to think about how we're bringing the mental health professionals in, whether that's a visit or a guest speaker. So I think, you know, where they're on Zoom and they're able to provide a presentation like this to family members, but also to the teachers, or a space where teachers can have that conversation about what they are seeing in their classroom. Because it's so important to talk about what are we actually seeing. I was there after Hurricane Katrina to be in the classroom, and I was able to see things that were taking place that wasn't considered part of the norm of what was happening in the classroom. And what the solutions came from us bringing the teachers together with someone able to facilitate a conversation about mental health to be able to come up with some of those solutions. And one of the solutions that they came up with was that children had a disconnect now, they didn't have this strong relationship anymore with weather, with rain, because rain had become this fear factor for them. And so the work had to come from lesson plans, whatever you have to help them to learn, how do we help them to rebuild their relationship with the weather? And next slide, please. So intentional self-care is what I always recommend. And when I say that, I want to really highlight intentional. So it's that we are looking at the various parts of our life where we may be not thinking about how to take care of ourselves. So one of the things that, for instance, I'll start with just sensory self-care. You know, if children are, if you're in the classroom and you have children who are doing a lot of crying, and you're finding ways to kind of help them to soothe themselves and to soothe them, and your organization has figured that out, but yet you are becoming overstimulated by the sound of, you know, what you may see in a deeper, where you're thinking about these are children. Normally I can help them, I can help to calm them, but right now I don't seem like I'm able to do that. That when your break time comes, just realize that you actually need time for that sensory relaxation. And that may be, if it means, and right now I want to say to go for a walk, that may not be the option right now if you're close to where ash is falling, but you figure out another way. Like for instance, do you need to sit and just listen to, you know, put earphones on and listen to comforting music? Or listening to a book, whatever it is that you need to take care of yourself in that, what we call self-care. But everyone's self-care is going to look very different. And so it really means sitting down and figure out for yourself, what do I need? One of the things that, even self-care and movement, because right now we are sheltering in place. We also are trying to stay away from, you know, being out in the air. figuring out what do we need in order to move. And when I say about self-care and movement, I'm not talking about exercise, even though exercise is, like you have some people who love, running for so many miles or being on their stationary bike and riding it for like for 50 miles or whatever it is that they like to do. When I'm talking about self-care and movement is that if that's what comforts you and brings some relaxation to you, that's your self-care. For me, self-care and motion may also be, watering the flowers. I'm moving now. And so getting up and really watering the flowers or doing something that gets you moving your body. And so, but it's part of that mental health, making sure that you're taking care of yourself, that you're still moving. And I have to, I joke a lot, so I'm gonna just go ahead with my little joke, which is that, walking back and forth to the refrigerator is not it shouldn't be a part of your self-care if your doctors say that it's causing too much stress on your body from eating too much. So anything that's gonna harm your body or harm you taking care of yourself is not a part of your self-care, your intentional self-care plan. One of the major big things that I think that we all carry around with us is that we carry around being able to breathe. So we really have to, at this time, is especially if you do not have in your life right now a daily time that you're breathing, that you're doing something. And what I mean by that is deep breathing. Where you're breathing through your nose and you're holding it and you're releasing it. And if you just try it right now while we're sitting, so we have 500 and something people in here. And so if 520 people could give it a try where you just deep breathe, and those of you who do yoga and relaxation, you know what I'm talking about. There's this feeling that just comes from doing it. And I think that it's an important part of our life that we need right now. Because what it does is that it won't solve the problem. What it does is that it helps you to find a place, and intentional self-care does this also. It helps us to find a place where we can find clarity to be able to solve the problems that are coming up, and to be able to answer questions to parents and to families that need to be answered, and coming up, making those decisions that we didn't have to make yesterday, before all of this took place. There are things now you're having to think about and try to solve that you weren't doing before, which is really taxing on just your sense of, I am a competent teacher, but now you're being thrown all of these things that's maybe making you question that. And if it is, I would say find a place of clarity so that you can see that right now we have a lot being thrown at us. And so it's going to take thinking out of the box. And that what I mean is, when I say that, is bringing people together to say, here's something that has come up. I have my ideas for how to solve it, but can someone else give me what ideas they have as well? So breathing, I think what it does is that it just helps us to find a sense of clarity. And so what I do is that I have where I use the 4-7-8, but I always say it's not really about the numbers. What it really is about is making sure that the ratio, like for instance, when you breathe, you're breathing in through your nose, that is shorter than you're holding, and then breathing out is slowly, and it's coming out in a slow way to really take a deep breath. And there's many different ways of doing it. This is just one that I'm offering, but I would say to find ways to really begin to put breathing in your life, as well taking care of the relationships that you have. So again, connecting with individuals who you may not have connected with before, but you know that they have brought you comfort. One of the things that I have come to enjoy, I'm not that crazy about talking on the phone all the time. However, one of the things I noticed is that people I haven't heard from a while have been sending me text messages, and I can't tell you how comforting that is, that I look and I see that name and I go, oh my gosh, I haven't talked to them in a while. And so I had to think about why is it that popping up their name? Because they brought me some comfort. And so I have to think about, self-care in relationships is who do I reach out to in those times when I'm really stressing about what's going on, whether it's at work or at home. So if I can go to the next slide. I really would like for us to just take the time to just stop for a moment. You received a lot of information today with the other presenters, where they gave you wonderful information to kind of help us with understanding what's happening as far as COVID goes, the pandemic, you know, and what do we know as being best practices? What are the numbers saying, and what have we learned from those numbers? And I think it's important for us to now just take the time to take a deep breath and just realize that you deserve that. And every day, I find 3 times a day to do some deep breathing, especially because I really truly feel that we shouldn't be deep breathing when a problem comes up. You know how when that problem takes place and we're going, oh. How about we do some deep breathing also in those times when we're actually feeling okay? Because that's a part of just taking care of our mental health, taking care of ourselves. So with that, that's where I'm going to end and just say that if we can just, you know, 500 and something people in here, if you can just take a moment to give yourself, you know, the opportunity to have a deep breath and just know that you're worthy of every deep breath that you take. Thank you.
Thank you so much, Cheryl. Just you even mentioning the words take a deep breath is making me slow down and pause, so I appreciate it. I'm going to ask you just one question before we bring back all of our speakers for our final portion of some questions and answers. And this is a practical question that a teacher actually wrote us. And I'll read it in quotes here. So, oftentimes at this time of the school year, I need to literally pry my students off of their caregivers during drop-off. This year, it's going to be even more challenging because parents can't come inside to ease the transition and because many kids have been out of childcare for so long. So do you have any suggestions for reducing a child's stress during that separation period? And I may ask if we can just broaden the question to how you think teachers can best support any child who's feeling sad or hurt when they can't use some of their typical coping mechanisms.
Yeah, I'm gonna go back to what we know about transitions. And that's how, and so with children transition, the more that more the family information the family have, but also the more the children information the children have, sometimes that can bring comfort. So we have done things like, you know, during transition, if there's a window, we've taken the children to the window so that they can say bye to their parents, even if they're crying and while they're going through that transition, that we still use that and make it a routine, that maybe that window, or like some teachers are doing, there isn't a window there. However, they do have the capability to have parents to FaceTime or into the classroom to be able to see and say bye to their children and to remind the children that they're coming back, you know, to pick them up, and being able to see the child, the adult talking with with their parent, whether that's on the computer or whether they're seeing them or on the phone. That sometimes brings comfort to children. So I would say the things that we are doing right now in routines is pretty much, we're having to really build them up and do them even more so. Realizing that transitions, you know, the pictures of their families, that's important. But all those things that we have in place right now are truly important, but also informing the parents, the families about what's going on. And if the support is needed within the organization, that we have those conversations, because you don't know what children you have and who you'll have in your environment. You may have one child who really is having a hard time to adapt, which means that you're not giving the other children as much attention. So the conversation within the organization may have to take place that I actually need maybe someone else in the room at the same time to assist, based on however number of people that are being allowed in that room. And earlier there was this discussion about the number of children, you know, in groups. And so maybe it may also mean to have those conversations as well, whether or not the teacher has too many children, because one child may be more stressed than another child, but it's the conversation that has to take place. And I think, yeah, one answer won't answer for everyone, but that's one idea that I have. And I just have to say, we have to validate everyone's concerns that they have right now. And that includes the teacher who is saying that it's going to be a challenge. And we know it will be a challenge. But having, like I said, the pictures of the classroom, coming up with ideas and ways to assist in this transition. It means having conversations to come up with our own tools and ways of handling our own strategies that we'll use. I hope that answers the question, that it helps somewhat. Yeah.
Thank you. No, I think it does. Provides a lot of pearls of wisdom there. At this time, I'll transition back to Dr. Kuo, who's been monitoring the live questions and answers submitted from the more than 600 of you that have joined today to moderate this final piece of our collective conversation. Thanks.
Thank you. It's a real testament to how important these topics are, and to the dedication of those of us and those of you in the early care and education sector. Thank you so much for your commitment. So we do have some questions we'll try and get through. The first one I'm going to put to our first speakers around infectious disease. And as we're heading into cold and flu season, how can we best support young children and parents besides getting the influenza shot vaccine? It will be really critical this season, as it is every season, but perhaps more so. And if all the panelists could put their video on.
Did you want me to answer that, Rhonda?
Sure, Ted. Yeah, Ted or Sohail. Yeah, Ted, go for it, please.
Sure. So the first would be to echo what you just said, get your flu shot. And we're not just saying that because we always say that, but because when someone has the flu or a cold, it's not that it makes you more likely to get COVID, of course, it's that it makes it just all the more confusing. You have to treat people like they might have COVID, they might be shedding more COVID because of those things. And so we really need to be more cautious than we usually are. And when the school says stay at home if you have a fever and cold symptoms, you really do need to do it. And not just, again, because you're a kid, but because of thinking if that cold gets transmitted to another child in the classroom, then the same confusing, challenging circumstance kind of spreads down the line. So I think we have to appreciate it's just going to be hard. There's going to be a lot of extra time with kids kept from school. But I think we have to do our best to keep that going so that we can keep the schools going for those that can attend. Yeah, and I guess I wanted to put one positive spin on that if I could, which is to say all these measures that we're doing to prevent COVID should actually also help prevent a lot of other infections. I mean, most colds are coronaviruses, and influenza itself should also be less of a problem this year. We'll still be getting transmission from homes and other settings, but it should also help to reduce the burden of those infections in school and other childcare settings.
Great, thank you. I'm going to ask one more question. I think it may be still for you, Ted, because it's a unique setting in that a lot of our early education and care settings the workers are in intergenerational families, and often the care settings are in the home with the intergenerational families. And how do you advise that they navigate this challenge around COVID-19 transmission with often older family members around? And this may also go to Abbey or Bobbie.
Great, maybe I'll just make a quick comment and pass it off. I think you have to be aware of it. And I think it would apply also to people living in the home that have other medical problems that might put them at higher risk for severe disease. I think we have to recognize that once kids start attending schools and childcare settings in person, what might have been a relatively tight kind of pod or space where a risk of transmission is being controlled is no longer. We have to, the transmission at schools seems low, but the cases that we talked about in studies in Australia and others, often the cases transmit more efficiently at home because of course people are in much longer, closer contact at home than they are in school settings. So it's unfortunately, it's a real risk. And I think we have to be cautious. I think the extent to which you go is going to be, dictated a bit by the scenario, depending how at risk and how old that person is, how possible it is to kind of limit separation. And I think when, infants and children have colds, it'll just be, again, all the more important to kind of try to keep them separate from the household members that are at elevated risk.
Thank you. And there is a question about children with special healthcare needs and should they even go? So they're linked together. Abbey and Bobbie, do you want to add anything to that?
I think as Ted said, I think it's really important to protect the elderly and the vulnerable. And we know with COVID that they do have the highest rates of hospitalization and unfortunately mortality. So it is a risk that we need to be aware of, and people need to think about that. And as Ted said, the highest transmission of COVID is in the household. So if a child is living in a multi-generational family with an elderly person, then if that child is going to childcare, they have to weigh the risk of, is that a good situation? Is that going to be putting anyone at risk? But I also think that if we do go back to our public health measures and making sure that people are wearing masks outdoors as much as possible, washing hands frequently, we can still reduce the risk. I think the other issue about elderly and people who are older, it came up a lot in the beginning about family childcare. We really worried because a lot of family childcare providers are elderly and have comorbidities and are at risk. And I actually was surprised in looking at the data. Family childcare providers have done really well. And they haven't closed as much as childcare centers, but they have smaller groups and they are adhering to the principles of the public health measures. And I think, as Naomi said, when you're reading the papers and you're hearing about these high numbers, read about the places in terms of, are they adhering to what we know are the good public health principles? And we do know that if you don't, and you break down some of those things that might be considered hard at first, like wearing masks, then people are going to be at higher risk. Bobbie, do you have anything else to add?
Actually, if it's okay, you guys will add to this next question, which is about ventilation. And we just have one, well, just maybe 1 or 2 minutes. So just, but I did want to ask this because we're in the middle of a very, smoky time period with fires going on, and yet ventilation is really important. So what counts as good ventilation in that beautiful chart that you had with the green and the red? What is good ventilation? Open windows, air filters, something else, especially with the fires?
Well, this is a huge issue. And I would say I'm not an environmental health expert, but I have learned a lot. And we know that HEPA filters are really important in terms of the type of filter that you have. Having an air purifier is really great, especially right now with the fires. And also checking the filtering system in the building that you occupy. Talk to the facilities people to find out if they have changed the filters to make sure that it is clean. And the problem right now is we always say open windows. That's the most important thing for ventilation in the childcare. Going outside is the best. So right now, because we are indoors, it really is, I think, check with facilities to see what the ventilation system is, if the filters have been changed. And other important thing is make sure you don't have a lot of dust, and make sure that you're using a HEPA filter vacuum to clean the dust, because we have a lot coming in and settling on the ground, which is where the children spend time. So you want to be able to vacuum very often and clean and mop the floors.
Great, thank you. There's a lot more that could be said, so much information, really appreciate all the panelists. I'm gonna hand this over to Dr. Dana Long, who's a pediatrician at Benioff Children's Hospital's Oakland's Claremont Clinic and the co-director of the Center of Child and Community Health with me. Thank you, Dana.
Thank you so much, Anda. What an amazingly rich conversation this was. I just wanna close with a quote from Shirley Chisholm. And she said, "You don't make progress standing by the sidelines. You make progress by implementing ideas." I truly hope that you learn tips and information that can help you all as childcare providers. And I also want to say that intentional self-care is an active process, so that is not standing by the sidelines. We are here for you. We are totally committed to you. Next slide. And generously, Hively has offered to help to continue to support the work we're doing by offering space for the conversations to continue. They're offering listening sessions and drop-in Zooms. You can see the hours are Friday mornings, 11 to 12 noon. We also want to be able to continuously support you. If we can attend the listening sessions, if there are more webinars that we can do to distribute information, please let us know. There are so many questions. I think I counted over 100 questions in the Q&A. We are going to answer each and every one of those questions to the best of our abilities. We will send an email out with the answers. We also will be in touch. We're going to be sending you an evaluation. And I just want to thank you for the work that you're doing every single day during this really challenging time. You are really helping to shape young minds and our future. And we need young children to help save us from the mess that we've created as adults right now. I want to thank all of our sponsors, and our sponsors include the UCSF Benioff Children's Hospital, the Department of Pediatrics, the Center for Child and Community Health, UCSF Cares, which is the collaboration to advise on reopening education safely, the Alameda County Office of Education, and Hively. Thank you so much. You will hear from us. Have a good evening.